So hello everyone, welcome. So my name is Luke. I'm the head of communications and support at the TSA. And we are absolutely delighted to be hosting today a session all about epilepsy in TSC, focusing on Epidiolex, but we're looking at the TSC, the pipeline in general for TSC-related epilepsy. I'm going to go through a few things very quickly because I know you'll be keen to hear from Dr. Sam Amin, as I am. But just to let you know, we've got quite a lot of people in today's session. There will be opportunities for questions. You can do that either by just putting your question in the chat box while Dr. Amin is talking, or if you wait to the end, we'll have some time for questions then as well. Because we've got so many people in this session, understandably so. If you can keep yourself on mute, that would be appreciated, just to keep things a little bit easier for everyone to follow and understand. But if you do want to ask a question at the end, do unmute yourself. You're more than welcome to, and we can take it from there. So yes, as I say, I'm going through this as quickly as we can to make sure everyone can listen to more of the good stuff. So without further ado, I will hand over to Dr. Sam Amin, consultant pediatric neurologist, and as I say, we're just delighted and so thankful for Sam for doing this. So Sam, over to you.
Thank you very much, Luke, for this nice introduction, and good evening, everybody. I'm going to talk to you today about epilepsy in TSC. I will give you an overview of TSC and epilepsy, and I will talk to you about some treatment options for epilepsy in TSC. I will briefly mention some conventional anti-epileptic drugs. I will also talk about non-medical therapies, surgery, Everolimus, Metformin. I will mainly focus on Epidiolex, CBD as well. And we will talk about some other newer drugs, including Ganaxalone, Phenfluramine, and basimglurant. So you probably know about the epidemiology of TSC. The birth incidence is around 1 in 6,000. And epilepsy is not uncommon in individuals with TSC. It's about 80% of people with TSC can have epilepsy. This was an interesting study. It looked at different types of seizures in individuals with TSC. As you can see, people with TSC can have different types of seizures. You will see here all the types of seizures. You can have complex partial seizures, you can have infantile spasms, you can have tonic seizures, clonic seizures, atonic, floppy seizures, myoclonic, and so on. It's unusual to see typical absent seizures in TSC. You can have atypical, but we don't normally see typical absent seizures. Generally, people with TS have focal seizures. Almost always is focal. And the focal seizures can become generalized. So you have one part of the brain is generating the seizure activity. So from one part goes to other parts and becomes generalized. Generally, people have seizures before the age of 3 years. However, we sometimes see people present with epilepsy later on, but generally is during the first couple of years of life. And sometimes managing epilepsy can be problematic. The epilepsy can become refractory to medical treatment. So it's very important that we treat infantile spasms very promptly, very effectively, because we know if you have infantile spasms and if your spasms are not treated well, then you are likely to have poor neurodevelopmental and cognitive issues in the future. So the lead time is important. Lead time is the time between the spasm and starting treatment. We know from studies, if the lead time is short, you are likely to have better neurodevelopmental and cognitive outcome. So why do we get seizures? Why do we see seizures in TSC? Well, we don't exactly know the pathophysiology of seizures, but we think it's probably because of the tubers. So you may have heard of tubers. You can see this is an MRI scan. You can see these white patches there and there. You can, if you look at the other side of the brain, right side, you can't see any white patches there, whereas on this side, you can see some white patch there. So these are tubers. We think people get seizures in TSC because of these white sclerotic patches. They are called tubers. Sometimes the areas around the white patches can also cause seizures. And we know that when we surgically remove these tubers, you can still have seizures. And it's probably because the area around the tubers become a bit irritated and they cause seizures. There is another theory that seizures happen in individuals with TSC because of mTOR pathway overactivation. You may know when you have TS, you are likely to have a change in either the TSC1 or TSC2 genes, okay? And when you have this change, this pathway in the cells becomes overactive. They don't stop. The pathway works constantly. If you look at this diagram, so you have power supply here. So that's kind of like the mTOR pathway. You have power supply, you have a switch, and you have the light bulb there. So if you have a change in the TSC1 or TSC2 gene, so the switch doesn't work well, and then you have constant power supply to this light bulb. So you can't turn this light bulb off, okay, because your switch doesn't work, because you have a change in the TSC genes. So this pathway, the mTOR pathway, is constantly overactive, constantly sending signals. There is no blockage because you have a change in one of the genes. And we think this mTOR pathway overactivation can also cause seizures. So traditionally, we have been using anti-epileptic drugs for epilepsy in TSC. In children, in babies, when they present, you may know, we use vigabatrin. And vigabatrin has been shown to be quite effective in babies. Having said that, we have not done big trials to compare vigabatrin with other drugs. So we don't really know if there are other better drugs for infantile spasms in TSC. There was a small study in France about 30 years ago. They compared 10 or 12 patients. Some received vigabatrin, some received steroids. Vigabatrin works better. But because the study is small, so we can't be certain that vigabatrin is the best treatment option for infantile spasms. So I think there should be more studies in the future looking at other drugs for infantile spasms. As you know, infantile spasm is very important to be treated promptly because we know it can lead to poor neurodevelopmental outcome if it's not treated well. Other drugs we use for seizures, for example, topiramate, lamotrigine, carbamazepine, and Keppra and clobazam. So in my experience, carbamazepine is probably one of the best drugs in TSC and epilepsy. And it's good for focal seizures. And we know most people with TSC have focal seizures. And clobazam is also a good drug. However, clobazam can cause sleepiness. There are other non-medical therapies, for example, vagal nerve stimulation. Some of you may have vagal nerve stimulation, or you may have seen it. It can be useful as well. It can be effective. The efficacy of vagal nerve stimulation in general in epilepsy about 50%, and it's reasonably safe. The operation, it doesn't cause a lot of problems, so it's worth considering VNS. The only problem with VNS in TSC, if you have a VNS, you will not be able to have kidney MRI scans because of the magnetic field. You can still have brain MRI scans because there are special coils you can go through. So it's safe to have brain MRI scans, but it's not safe to have kidney MRI scans. As you know, a lot of people with TS may need kidney MRI scans to monitor their kidney angiomyolipomas. So it's important to consider that before going through VNS insertion. There are other options for managing epilepsy in TSC. Surgery is another option, brain surgery. Again, it's not easy to perform brain surgery because a lot of people have multiple tumors in the brain, as you've seen on the MRI scan, and it's difficult to know which tumor to remove because sometimes when you do tests, it's hard to identify the problematic tumor. A lot of them can generate seizure activities at the same time. So it'd be very difficult to know which one to remove. Obviously, there are tests you can do to identify that. For example, if you look at this picture here, this is a functional MRI scan. It tells you which part of the brain is active, which part is more important than others. And if you look at this picture, this is another special scan that tells you again about brain, different parts of brain, and tells you about different activities. This picture shows an EEG. Some of you may have heard of EEG, and some of you probably seen EEG. This is a different EEG. The EEG leads are put inside the brain, inside the skull, to identify the problematic tuber. So that can be useful as well for epilepsy surgery planning. These are some pictures to show you some surgery types. We've learned that tubers can cause epilepsy, and tubers can be removed surgically to improve seizures. As you can see, these two imaging pictures, this person has a tuber there. This is after surgery, the tuber has come out. There are other approaches can be taken. This person had hemispherotomy. Half of the brain, almost half of the brain has been removed because this half was creating a lot of seizure activities. There is another technique can be used, and this technique is called corpus callosotomy. This is useful for drop attacks. Some people have significant drop attacks, and they can be quite dangerous, the drop attacks. So this procedure is useful for drop attacks. This part of the brain is called corpus callosum. That's before surgery. This is after surgery. As you can see, the corpus callosum has been removed. Then now focusing on other medical therapies in TSC. Some of you may have seen this picture before. This is Easter Island, Rapa Nui. A drug was discovered in the soil of this island called rapamycin. You may have heard of rapamycin. Rapamycin is an mTOR inhibitor, and we know mTOR pathway is a problem in individuals with TSC. So rapamycin has been shown to be effective and to block this mTOR pathway. Then another drug was manufactured called Everolimus, and Everolimus was found to be effective, like rapamycin, and blocking the mTOR pathway. So Everolimus was used initially for brain tumors, subependymal giant cell astrocytoma in TSC, and it was found to be effective. Then Everolimus was used for epilepsy in TSC, and there was a big international study. Again, the study looked at the safety and efficacy of Everolimus in TSC. As you can see in this slide, so this shows you 3 different groups. So you have group 1 here. These people were taking only placebo, sugar pill, and this group was taking the small dose of Everolimus and high dose of Everolimus. As you can see, 40% of the patients had significant seizure reduction, more than 50% of seizure reduction. So it's clear from this study that Everolimus was effective for epilepsy in this population. And also this graph shows you the same 3 groups: placebo, small dose, and high dose. Again, you can see the median reduction was nearly 40% in those individuals who were taking high dose of Everolimus. Some of you may be familiar with Everolimus and its side effects. It can cause problems. It's an immune suppressant drug. It can affect your immune system. The commonest side effect with Everolimus is mouth ulcers. As you can see here, a lot of people had mouth ulcers. But generally, it's a kind of a temporary side effect. It should get better when you take Everolimus for a long time. Then following that, Everolimus became available in England, and NHS England approved Everolimus for epilepsy in individuals with TSC age 2 years and above. So this just shows you the pathway if you are not familiar with Everolimus in TSC. So obviously you have to have a diagnosis of TSC, then you should have tried at least 2 anti-epileptic drugs before, then your case should have been discussed for epilepsy surgery. Also, you should have been considered for vagal nerve stimulation and ketogenic diet. And if these options all failed, not satisfactory, then you can be considered for Everolimus. Then we recently completed a study. Some of you may have already taken part in this study. We used Metformin in tuberous sclerosis. And you may know Metformin is a drug has been used for diabetes for many years. It reduces blood sugar. But we've learned Metformin can work on the mTOR pathway and inhibit the mTOR pathway in TSC. So we thought maybe it's useful to use Metformin and see whether Metformin has any effect. So you can see 2 graphs here. That's looking at the effect of Metformin on Sega lesions in the brain. So this is the first group 1. These people were taking Metformin, and these individuals were taking placebo, sugar pill. And you can see any downward graph is a reduction in Sega size. As you can see, a lot of people had significant reduction in their Sega lesion were taking Metformin. Whereas in the placebo group, the sugar pill, you don't see many reduction here. So it was clear in the study that Metformin was helping the Sega lesion. Then we looked at their epilepsy as well in the study. As you can see here, we saw a mean reduction of 43% of seizure activity from baseline. And we saw only 3% reduction in seizure activity in the placebo group. So it was clear that Metformin was helping the seizure activities in this population. Then now focusing on Epidiolex and cannabidiol, some of you may have heard of this product. It has become very topical in the last couple of years. You've probably seen it in the news as well. People have been talking about Epidiolex for epilepsy in various conditions. You may know Epidiolex is derived from this plant, marijuana, and this plant has more than 100 active compounds. Okay, and this plant has been used for epilepsy for many years. It's been around for more than 100 years, so it's not a new product for epilepsy. And cannabidiol is a chemical substance derived from this cannabis sativa plant. And you may know about THC, which is an active ingredient, okay? It's a psychoactive part of this compound, and some people use it for recreational and purposes, and so-called like you get high with using THC. And we don't really know the effect of THC, but there is some evidence to suggest that if you take high level of THC, it can affect your IQ, it can affect your mental health and your brain development. So it's important when people use these products to make sure that we are aware of the THC level, the percentage of THC in these compounds. So cannabidiol has been used for different neurology and non-neurological conditions, has been used for epilepsy, has been used for anxiety, for pain in Parkinson's disease, has been used for stiffness, joint stiffness, spasticity, and abnormal movements, so-called dystonia, and other non-neurological conditions like Crohn's disease. We don't exactly know how it works in the central nervous system. So this picture shows you a neuron. So the way the neurons, the cells in the brain talk to each other through some chemicals, and one of them is calcium. So the neurons, one neuron releases calcium to another one, and that's how they talk and communicate. And we think that probably CBD Epidiolex is helping with the calcium release and calcium take between the cells. So GW Pharma, pharmaceutical company, produced this compound Epidiolex in recent years. And this compound has a very small amount of THC. It's about less than 0.1%. And this CBD has been used for two conditions commonly, Dravet syndrome and Lennox-Gastaut syndrome. And this was after using Epidiolex in a big international double-blind randomized control trial. And if you want to use a new product, it will have to really go through a proper scientific trial, a double-blind and randomized control trial. And that's the only way you know the efficacy of of a new product, because you will blind the clinicians. The clinicians wouldn't know who's taking what, and the patients wouldn't know if they are on placebo or if they are on the active product compounds. And at the end, you look at their results and then you compare, still blinded, then you will know if the drug has worked or not. And that's the kind of a gold standard method for investigating drugs. So the company conducted a large trial using CBD in patients with TSC. Some of you may have taken part in this trial. You may be aware of it. So there were three groups. So one group took Epidiolex up to 25 milligrams per kilogram per day, one group 50, and one group took placebo sugar pill, but absolutely nothing, no effect for 16 weeks. Obviously, there was a titration period and then was maintenance. So you take the dose and you slowly go up. You don't want to go up immediately. Then there was inclusion and exclusion criteria like any other study. So the patients were aged 1 to 65, and they all had significant amount of seizures, at least more than 8. And they were all on at least one anti-epileptic drug, okay? And their epilepsy treatment should have been stable for 1 month prior to screening, because you want to make sure that you don't make too many changes at the same time, because you want to know whether your new product is likely to be effective or not. Then this slide shows you some baseline demographics. We know it was 3 groups: placebo, small dose, and then you have high dose. This slide shows you some more baseline characteristic, more about the patients in different groups, and about their drugs, and that's useful. So there will be a slide on this, and you will realize that the importance of this slide when we see the other one about different drugs, because you want to know if your Epidiolex is more effective with one type or different type of antiepileptic drugs. So this slide shows the effect, the result of your product, the CBD. So you have three groups. Yeah, you have placebo group here. We have another group who were taking 25 milligrams per kg per day, and another group 50 milligram per kg per day. And you can see that's the seizure reduction, percentage of seizure reduction. And you can see those who were taking Epidiolex had significant seizure reduction, nearly 50% seizure reduction compared with the placebo, which was 30. The placebo effect was quite high, 30% of seizure reduction in the placebo group. It's slightly unusual, but it's possible. But you can see the difference is quite significant. So if you take Epidiolex, you are likely to have significant seizure reduction. Okay. And this graph shows you different analysis. Again, you have got three groups: placebo, 25, and 50 milligram per kilogram per day. As you can see, a lot of the patients, nearly 40% of the patients, had more than 50% reduction in their seizure frequency. And some patients had more than 75% reduction. That's quite significant, 75% reduction. So what was interesting here, if you take Epidiolex CBD with clobazam. So if you take Epidiolex with clobazam, you are likely to have 60% seizure reduction. That's quite significant. You don't see this with many other products, with many other antiepileptic drugs. But if you take it without clobazam, your seizure reduction is around 40%. So we've learned that if you take Epidiolex with clobazam, it's likely to be effective. This slide shows you some side effects of clobazam, of Epidiolex. The commonest side effect we see with Epidiolex is stomach upset and diarrhea, and generally it's a temporary, transient side effect. But for some people, they may have to stop taking Epidiolex because it can be bad. Somnolence can happen, and it can affect your liver function. So it's important when you take Epidiolex to have your liver function test checked, because it can increase your liver enzymes. And it's generally dose dependent in most people. So if you reduce the dose, your liver function can get better. So it's unlikely to be a kind of an irreversible problem, but you just have to monitor that and remember to check your liver function test. So the study concluded that both the 25 and the 50 milligram per kg per day doses of CBD reduce seizures significantly compared with the placebo group. And a lot of people who were taking CBD had significant seizure reduction, and some people had more than 50%, and some had more than 75% reduction. And that's quite significant. And patients and caregivers in the CBD group reported improvement in overall condition, not just epilepsy, in other domains, for example, quality of life. And we know the safety profile was reasonable. Obviously, if you take higher dose, 50 milligram, you may have more side effects compared with 25 milligrams. But the study showed that even if you take 25, is almost effective as the 50 milligram per kilogram per day. So there is no need to use 50 milligram. I've never used more than 20 milligram per kilogram in anyone So I don't think you will need to go that high. So is Epidiolex available for TS? Well, kind of yes and no. So we know in the UK, Epidiolex is available only for Lennox-Gastaut and Dravet syndrome, okay? And if you have to prescribe Epidiolex, you need to prescribe it with clobazam, because you know the studies have shown that Epidiolex is likely, well, it's more effective if it's used with clobazam. So it has to be with clobazam currently. And you can only prescribe Epidiolex for those people who are 2 and older, so you can't prescribe for younger. And the starting dose, we start on a very small dose. You know, in the trial, one group received 50 milligram per kilogram, whereas we start generally at 2.5 milligram per kilogram. So it's a very small dose. And if you start slowly, then you are unlikely to have significant side effects like drowsiness and liver problems, etc. And the drop attacks, the seizures, have to be monitored. So you have to have a diary, because at 6 months, you have to show that you have seen significant seizure reduction, at least 30%, so that you can continue with the drug. So Dravet syndrome, it's a completely different condition. It's caused by a different gene. It's totally different from TSC. Whereas Lennox-Gastaut, it's a description of a seizure epilepsy type. So you could have TSC and Lennox-Gastaut. You could have brain injury and Lennox-Gastaut. Your seizure could be due to infection, and you may have Lennox-Gastaut. So it's important for people with TSC to be assessed for Lennox-Gastaut, because if you have LGS Lennox-Gastaut, then you will be eligible to take CBD now in the UK. And how do we diagnose Lennox-Gastaut? It's not easy. So you have to have certain type of seizures, for example, drop attacks. So drop attacks are important, either atonic or tonic drop attacks. And also you have to have some certain EEG features. And a lot of people with refractory epilepsy and difficult epilepsy are likely to have Lennox-Gastaut. So it's very possible that some people may have Lennox-Gastaut and TSC, and they've not been offered Epidiolex. So it's important to revisit that. So what about Epidiolex for TSC in general without Lennox-Gastaut? So the process is a bit more complicated. So at the moment, Epidiolex is not available for TSC in the UK without Lennox-Gastaut. So the company is working on this, and then they are trying to get approval and approval from the regulatory authorities to make this drug available. And TSA has done a lot of work helping the company, writing supporting documents to make sure that this drug is available for our community. So good news from the GW Pharma that a couple of weeks ago, the European Medicine Agency has adopted a positive opinion on this product. So that's a really good progress, because without their positive opinion, there will be no progress with this product in Europe and the UK. But the starting point has been positive. So that's really good news for Epidiolex progress in this field. So after this, this proposal will be reviewed by the European Commission, the EC. Then the EC will decide whether this product should be used or not. I think it's very likely they will say yes. It will be unlikely for them to say no. And then this process may take about 2 months for EC to say yes. Obviously, things are a bit complicated now with Brexit. Pre-Brexit, EC would have been very important part of our regulatory authority. However, now things are slightly different. So we have our own regulatory agency. You've probably heard of MHRA during the COVID vaccination approval. So any new product in the UK will have to go through the MHRA, our regulatory authority, to make sure this product is safe to be used. So once EC is approved, hopefully in 2 months, then this proposal will go to our MHRA. Then MHRA will decide. I think it's very likely that MHRA will say yes, because the trials, as I've showed you, the trial has shown positive results and the safety profile is good. And we have been using it in Dravet and Lennox-Gastaut in the UK, and the results are good so far. So there are no major concerns with this product. So I'm positive that MHRA will approve this product. Once MHRA approved it, then it will go to our licensing body, the NICE guideline, the NICE and the SMC in Scotland. And it may take about 6 months for them to approve that. Once they've approved it, then the drug will be funded, then this product will be used. We will be able to prescribe to individuals with TSC and epilepsy without Lennox-Gastaut. Obviously, there will be some criteria for prescribing. It will probably be similar to Everolimus. So people should have tried at least 2 anti-epileptic drugs. And I'm sure most people with TSC would have tried at least 2 drugs. And also there will be some other criteria. For example, we should consider other options, for example, VNS and ketogenic diet before considering Epidiolex. It's not clear whether we have to use clobazam with Epidiolex in TSC. There's been a lot of discussion. We've had some meetings with GW Pharma, with other colleagues, to decide whether we have to always try with clobazam or without it. It's slightly controversial. Some people prefer to use it with clobazam. As I've shown you, the study has shown that if you use it with clobazam, your success rate about 60%, but if you use it without clobazam, it's about 40%. But some people may worry about using clobazam because it can cause drowsiness and some other side effects. So that's Epidiolex. Then there is another product called Ganaxalone. This product has been manufactured by Marinus Pharmaceutical. So Marinus is in the process of setting up a trial of TSC, of using Ganaxalone in TSC, and I've been very keen to make sure that this trial is run in the UK. And we've had some meetings with them, and they are very supportive, and they are keen to run the trial in the UK. So it'll be very similar to the previous trials using Ganaxalone versus placebo in individuals with TSC and epilepsy. So the way it works is slightly different from some other anti-epileptic drugs. It's we call this neurosteroids. It's a bit different from the normal steroids. It's a steroid in the central nervous system. And studies have shown that Ganaxalone can be useful for epilepsy, but in other conditions. There was a big study, and we took part in the study using Ganaxalone in a genetic condition called CDD, CDKL5 deficiency disorder. And a lot of people with this condition struggle with epilepsy. Their epilepsy is very difficult to control. And the study showed a significant reduction of seizure activity, 30% in those who were taking Ganaxalone compared with placebo, which was only 4%. And the side effects were not significant in people who were taking Ganaxalone. So it is quite positive. And the study concluded that Ganaxalone was effective in reducing seizure activities, and the side effects were not significant. So that was in the CDKL5 study, and there was a very small study, phase 1 and phase 2 study using Ganaxalone in individuals with TSC, and the study was promising, showing promising results. And for that reason, there will be a big international study using Ganaxalone in TSC and epilepsy. And hopefully we will be part of this trial in the UK. So some of you will be approached to take part, will be offered to take part in this study in the near future. Then I have recently approached a pharmaceutical company. They are using Phenfluramine. Phenfluramine, again, it's another new drug, has been used in Dravet syndrome. Again, Dravet syndrome is a genetic epilepsy. Phenfluramine is not a new drug. It has been out for a very long time. Initially was used for weight loss in obese adults, but again, it had to be withdrawn because some people had heart problems because of Phenfluramine. But it has come back again, and certainly in some epilepsy syndromes, in Dravet syndrome, this product has been very effective. So there was a big trial using Phenfluramine in Dravet syndrome. So we have 3 groups. You have placebo group, small dose, and high dose of Phenfluramine. As you can see, the side effects were manageable. They were not significant side effects. That's a very interesting slide. So this is the slide shows the effect of Phenfluramine on epilepsy in this population. So this is your percentage of the patients. As you can see, 90% of people who were taking Phenfluramine had 25% seizure reduction. Well, you may say, well, 25 is not really a good number, but then 68% had 50% reduction. That's quite significant. We don't see this that often with other drugs. 68% had 50, and 50% had nearly 75% reduction. It's significant reduction of seizure activities. Well, I thought maybe if it works for Dravet, maybe it works for TSC as well. I have approached the company and they've been very supportive. So hopefully we'll try to get a trial in using Phenfluramine in TSC as well. Obviously, the concerns about heart remains an issue, but when people take Phenfluramine, they will have regular echoes. And the issues you get with Phenfluramine heart is different from cardiac issues you get with TSC. But so far, people who've been taking for Dravet syndrome, they have not had issues with their heart. So maybe it is not an issue for. So the study, the Phenfluramine study, concluded that it was effective in reducing seizures, and the side effects were not significant. Then there is another product. We've been approached by this pharmaceutical company, Neoma Pharma. They are keen to use this new product, Basimglurant, in TSC. It's at early stages because this has not been used in bigger trials. So they are hoping to set up a phase 2 trial. So when you set up trials, you have different phases, and phase 2 is quite primitive, early stages, because you don't have enough data to use it in a bigger population. But the plan is to set up this a multi-center trial, and it will be a prospective, double-blinded, randomized controlled trial using this product in epilepsy in TSC. So this product works on a receptor in the brain between the cells called glutamate receptor. And we know these receptors are involved in seizure formation. So this product blocks the activity of these receptors. So theoretically, it should reduce the seizure activity, but obviously that hasn't been trialed in this in TSC. So we don't know unless you run this trial. But it looks interesting. And we have agreed to take part in the study. So the company is going through some feasibility assessments, but they are keen to set up this trial in the UK, and we've showed interest, and we'd be happy to support this study. So the trial is slightly different from the other studies I've showed you earlier. So as like any other trials, so you'll have a screening and baseline. So you'll have one group receiving the product and the other group will be receiving placebo. Slightly different from the other group, so you'll have this washout period. So people will be changed. If you were on placebo at some point, you will be on the products at different stage. Because most of the time when you take part in a trial, you will be either on placebo or the product. Whereas with this one, you will switch. So you will switch from placebo to the product, the active product, and vice versa. And then you will have an open extension at the end. So it's interesting, and I think it's worth exploring this option and see whether it's effective in TSC. So in terms of eligibility criteria, people aged from 5 to 18, as you can see, the inclusion criteria is slightly different from other trials. Because, you know, the other studies I've showed you, we've recruited people from one or sometimes from 2, whereas this trial is from 5. And just because it's phase 2 and hasn't been used in bigger studies, so, you know, regulatory authorities are always careful when using a new product in young children. Obviously, people will have to have a definite diagnosis of TSC to be able to take part in this trial. And obviously, you need to have active seizures, and your other drugs should be stable for at least 2 months prior to screening. So the trial is not open yet for recruitment, but hopefully we'll hear from the company soon. And as I said, we'll be very keen to take part and make sure people have the opportunity to take part in this trial. So thank you very much for listening. I hope this was useful, and please let me know if you have any questions.
Thank you, Sam. Thank you. It's very interesting. I can see we've got one question in the chat box, which we've got already. So the question from David, which is a great question, is has a combination of Epidiolex and mTOR inhibitors been shown to give greater control than one type of AAD on its own?
Yeah, so thank you. It's a good question. We have not, because, you know, a lot of these trials made sure that people were not on mTOR inhibitors. So we don't exactly know the efficacy of combination of the 2 drugs. However, we know now a lot of people have been using Epidiolex in TSC who are on mTOR inhibitors through the Lennox-Gastaut diagnosis. And we know if you take both drugs together, you have to be careful about the level of Everolimus, because it can affect the level of Everolimus or rapamycin. Mm-hmm. So it's important that you have regular Everolimus and rapamycin level checked, because you want to make sure that you don't go into significant changes in the levels. But in terms of efficacy, I think it's unlikely to be more effective if it's used with mTOR inhibitors. So I think the advantage of using mTOR inhibitor is to shrink the lesions, the lumps related to TSC. I think there's no doubt that using mTOR inhibitors are useful for that. And if you use Epidiolex for epilepsy, then I think that probably with the most sensible approach, I think would be using mTOR inhibitors for lesions, whereas Epidiolex would be mainly for epilepsy.
Understood. Thank you, Sam. We've got another question coming from D, which is, do other medications have to be withdrawn to take Epidiolex, like sodium valproate and vigabatrin?
Thank you for asking this very useful question. No, you don't need to, and we always try to make sure that we don't make too many changes at the same time. So I think it won't be useful to stop another drug, so you don't have to. And we know Epidiolex doesn't interact with most of the other anti-epileptic drugs. So there is no need to make any changes. But at the moment, if you start Epidiolex, you have to start clobazam with Epidiolex. You cannot start Epidiolex alone. And you don't have to start a high dose of clobazam, because, you know, if you use high dose of clobazam, it can cause drowsiness and sedation, and some of you may have experienced this already. But you can be on a very small dose to avoid the side effects. But no, you don't need to change sodium valproate or any other drugs.
Thank you, Sam. Trying to whiz through these questions so we can get as many answers as we can. They're all great. So the next one from Amanda, I think that is metformin available for TSC patients? As I was told no.
Hi Amanda, thank you for asking about metformin. So metformin is it's an old drug. It's been around for a long time. And we know the safety profile of metformin. It doesn't cause a lot of side effects, and it doesn't cost much. I think it costs about 90p per month or something. So it is available. So most GPs are happy to prescribe metformin because they are familiar with metformin, because they have got a lot of people with diabetes and polycystic ovary disease who take metformin. So I would be very surprised if a GP refused to prescribe metformin, because they know the safety profile and they know it's unlikely to cause problems.
Thank you, Sam. Thank you. We've got lots of questions coming in now. So keeping on the metformin theme, I'm going to ask Rebecca's question now. Thank you, Rebecca. But I will go back to the others also. So could metformin be used to offset the high sugar levels sometimes caused by everolimus while also reducing seizures?
Yeah, it's a good point. There's no doubt metformin is useful for high blood sugar, but the way metformin works in diabetes is regulating the insulin sensitivity. Mm-hmm. So if your high blood sugar due to everolimus is not due to insulin sensitivity, then I suspect metformin may not help the high blood sugar. Because we know when people take metformin with TS, they don't get low blood sugar, so their sugar don't go down. It doesn't cause you hypoglycemia. So I think maybe I haven't seen many people having high blood sugar due to everolimus. So maybe it's worth having some investigations and make sure there is no other cause for the high blood sugar you are describing, because it may be something else rather than everolimus.
Thank you, Sam. There's a question from Kathy here, who said, Dr. Amin said that mTORs can shrink lesions. Does he mean tumors that sit on top of the brain like scars? We are on Advent, CBD, and Everolimus.
Yeah, so in terms of shrinking lesions, we haven't trialed using mTOR inhibition to see whether it's effective for topical lesions. Like, you're referring to lesions on the scalp, I'm assuming.
I think so.
We haven't seen. We know from experience and the studies that mTOR inhibitors are effective in shrinking other lesions like lung lesions, brain lesions, and kidney angiomyolipomas. Whereas for skin, it's slightly different. Obviously, we know it can work for facial angiofibromas because they are quite active lesions, whereas the one you are describing, they are inactive, and maybe the mTOR inhibitors enable kind of to penetrate these solid lesions, and maybe that's why it doesn't work on these lesions. But obviously, if these lesions become a problem, either cosmetic or functional, then they can be removed surgically if it's easy. That's one option one could consider.
Thank you, Sam. Thank you. I've got quite a few here. We'll whiz through as many as we can. And we may ask if there's any that we can't answer today. We may ask if Sam is happy to kindly answer them afterwards. So the next question we have is, can Epidiolex be used alongside the ketogenic diet?
Yes, absolutely. And there is no contraindication for that. Obviously, if you are on ketogenic diet, you will have to have regular blood tests, and that should carry on. and obviously, if you are on Epidiolex, and you will have to have some blood tests, especially checking your liver function test regularly, especially when you change the dose. So there shouldn't be a problem using both together.
Thank you. Now, JT, I'm going to assume you mean Epidiolex for this question, but just let me know if you mean otherwise. So JT's question is, would Epidiolex be prescribed for all / any seizure types associated with TSC?
Yeah, I suspect it will be similar to Everolimus criteria. So you have to have significant seizures. If someone has like one seizure every 6 months or very frequent with no impact, then I think it's unlikely to be available. But I think if you have active seizures and if you've already tried at least 2 drugs, then I think it's very likely to be available for its use. And I think that's probably purely financial, because the drug is it is expensive, and NHS England tries to restrict this expensive drug. And maybe there is some scientific evidence behind that, because if your seizures are not that frequent, then it may respond to other anti-epileptic drugs. So you may want to consider safer drugs like levetiracetam, Keppra, or some other drugs to see if they were. But I think, so yeah, answer to your question, I think you'll have to have active seizures. It doesn't really matter whether it's tonic or clonic, whereas now it does matter. So you have to have LGS, Lennox-Gastaut, and you have to have certain types of seizures. Whereas when we get approval, hopefully in the future, it shouldn't matter what type of seizures you have.
As I say, I'm going to save these questions down, and hopefully Sam will be able to answer these at a later date. But other than that, it's just to say a big thank you to everyone for joining today. Hopefully it's been helpful. It's been really interesting for me. I've been jotting down everything as quickly as I could. I'm very thankful that we've recorded this session, because I'm sure there's lots of great things that it's already gone out my mind already, so we can go back to that. Do keep an eye out for it. We'll be putting it on the website and on Facebook and whatnot. Do tell people about it as well. And other than that, yeah, I hope you're all keeping as safe and as well as can be expected at this time. So yeah, just keep an eye out, and always remember that we're here as well. So it's just me saying a big thank you to everyone now, and yeah, have a good night. So bye everyone.